you can record it. You can edit all that out. Good afternoon, everyone. Welcome to this month's webinar. And I'm very pleased to introduce, and actually a well-known person, Glenn Grabowski, Secretary and Board of Directors member of the Western Neuropathy Association. He himself, someone with a rather unusual diagnosis, will present a number of unusual causes of neuropathy, how they relate to some of the better known causes, and materials and approaches patients, you and I, can use to get their practitioners to consider some of these when testing for the usual suspects. Doesn't reveal a likely cause, as some of these unusual etiologies are very treatable. So the other thing is that we'll ask you to hold for questions at the end, and then I will help Glenn coordinate them, and I'm sure he'll do his best to answer all your questions. So I'm going to turn over everything now to Glenn. Glenn, it's all yours.
Okay, thanks very, very much, Daryl, and thanks all of you who are out there for coming to see this. We try and do these at least about once a month to address issues in the neuropathy sphere. And I was actually asked, again, as someone who has a somewhat unusual diagnosis, in my case, an acute onset body-wide neuropathy, to talk about some of the unusual causes of neuropathy and how they relate to some of the usual suspects. Many of you have probably heard the old shibboleth that there's several hundred causes of neuropathy that are known. There may be an equal number, particularly in the hereditary and metabolic realm, that are less known. But generally, and I'm sure people out there have had the experience of having gone to a neurologist's office complaining of symptoms with your feet or tingling, numbness, pain, getting maybe a few tests, an EMG, a nerve conduction study, some blood work for basic things, and then being told, well, yes, you seem to have neuropathy, but we don't know what from. Generally, unless your blood sugar is way out of whack, or there's like very obvious autoimmune situations, far too many people get diagnosed with the dreaded idiopathic designation. And part of what I was hoping to do today is to help people understand other avenues that might be taken in terms of testing and other things they could possibly suggest to their practitioners. We'll talk a little bit about that towards the end. But what I will now do is I'm going to do the screen share to bring up the lovely PowerPoint presentation. And hopefully you guys can all see that. It says I am now screen sharing. You can see here that this is the title page, with our logo, Unusual Causes of Neuropathy, and how to get medical professions to consider them, which will be the last part of this. Now, what I actually did in creating this is I borrowed very heavily from the works of Dr. Norman Latov, particularly a rather now old clinical application paper that he wrote in concert with the Quest Diagnostics people about various blood tests to reveal causes of neuropathy. I basically looked that over. I have a link to it at the end of this, which you'll see. And I expanded upon it to talk about categories of neuropathy causes in general. And then we'll talk about under each category some more of the specific ones. Some of these will be well known to people. Some of them I bet maybe not so much. And to do that, let me pull up this one here to talk about the general categories of things that cause neuropathy. And of course, we're not talking about, that dreaded idiopathic situation. Now we're talking about those things which are known to cause neuropathies and can be found out through various types of testing. The most common, because diabetes is the most common cause of neuropathy, are the endocrine and metabolic ones. Obviously diabetes and other blood sugar dysregulation, but there are others which you're going to learn about today. Some people know about thyroid problems causing neuropathy, rarer but still a possible cause, often leading, by the way, as a first symptom to things like carpal tunnel syndrome for reasons we'll get into. There are also nutritional and deficiency causes of neuropathy. A lot of these are vitamin or mineral deficiencies. B12 deficiency, probably again the best known and one that most doctors do know to test for, particularly in older patients. But there are a lot of other ones that can occur. There's also the possibility for vitamin B6 of getting a neuropathy either from having too much or too little, which is unusual among nutritional and deficiency causes. There are toxic causes, chemotherapy being the most obvious one. A lot of the chemotherapeutic agents that are used for breast cancer, gynecological cancers, lung cancer, are notoriously neurotoxic. Neuropathy as a side effect is very common with them. Hopefully, for people who have been in that situation, you had an oncologist who actually mentioned it. Too often that doesn't happen, and then you're very surprised when you get symptoms. But again, there are others, alcohol being one of them. Certainly, people who abuse alcohol are more prone to neuropathy, although there's a lot of individual variation here. And there are others you're going to learn about today as well, including from some of the unusual chemical exposures that people might have. It includes things like Agent Orange and the like. Immune-mediated neuropathies. Again, this is a category that some people know something about, particularly the people who might have either had Guillain-Barré syndrome or its less acute manifestation, chronic inflammatory demyelinating polyneuropathy, or CIDP. But there are a lot of immune-mediated neuropathies out there. There are some that are associated with the antibodies that produce a lot of the connective tissue or vascular diseases, things like lupus or Behçet's disease or Sjögren's syndrome. We'll talk about those. And there are, and a lot of this is based upon Norman Latov's work at Weill Cornell Center for Peripheral Neuropathy. There are people who manifest specific autoantibodies to parts of peripheral nerve. And we'll talk about that type of testing. That's really getting into the weeds type of stuff where your average neurologist, unless they're a neuromuscular specialist, is unlikely to know about. Other things, paraneoplastic or cancer-related neuropathies. Yes, unfortunately, for people who get cancer, they not only can get neuropathy from the treatments, but they can get it from the cancer themselves. There are ones that are fairly well known, such as the monoclonal gammopathies. These are associated with various blood cancers, such as leukemia, lymphoma, myeloma, where there is a cross reaction to the types of antibodies that are produced in the blood, which also attack parts of nerve. We'll talk about some rarer ones as well that are associated with lung cancers, gynecological cancers, and a few others. There are, of course, infectious inflammatory types of neuropathies. People sometimes forget about this, although there has been a little bit more attention paid to them lately because of the post-COVID neuropathies that are popping up here and there among people who have COVID or have long COVID. The most well-known among these is neuropathy from the result of infection with HIV. But the one that people used to know more about before they came up with antibiotics to treat it was leprosy. Leprosy is a disease that, among other things, causes deterioration of nerve. There are other ones that involve other infectious agents, both viral and bacterial, that we'll talk about as well. Compressive neuropathies. This is when people start talking about spinal stenosis in particular, or traumatic neuropathies, things that are caused by injury. These are neuropathies. It's certainly true that if you have problems with your spine, sometimes a doctor may not refer to it directly as a neuropathy. In fact, if there's a compression of the nerve root, they'll often refer to it as a radiculopathy, because radic is the Latin word for root. But these are neuropathies. They are something that is mechanical in nature, often treatable, whether it's through physical therapy or surgery. But in cases of trauma where nerves may actually be severed, possibly less treatable. And then the other major cause, and one we're finding is a lot more common than people had assumed, are hereditary neuropathies. We are actually not going to get heavily into this today. And primarily that's because the webinar next month that WNA is going to be doing is going to be on hereditary neuropathies, where Linda Pettiot from the Calgary Neuropathy Association has generously decided to give us a presentation on a lot of those. She has Charcot-Marie-Tooth, which is one of the more well-known hereditary neuropathies. But I can say that one of the great triumphs, Pyrrhic triumphs, but triumphs of the Human Genome Project has been discovering that there are an awful lot of conditions out there, although sometimes they affect very small numbers of people, that result in neuropathies and that are passed down from generation to generation. Some of these are better known than others, such as the hereditary neuropathies with liabilities to pressure palsies, which tend to flare up with compression. But there are a lot of ones out there that are known only by the particular gene that's affected. The best database that I know of these, as I probably mentioned to those of you who've been to some of our support groups, is the Washington University neuromuscular website, which is associated with Washington U in St. Louis. Since I've been in this realm, the list of hereditary neuropathies that they've got there has expanded probably fivefold in about 2 decades. It's just amazing what they've come up with. And they and the National Institutes of Health are the ones who seem to keep that database. But again, that's not something your average neurologist would know much about, but it's certainly worth investigating. So now that I've said all this, and hopefully you don't feel like you've just gotten a drink from a fire hose, I'm going to start talking about some of these individual categories and some of the neuropathic causes that come under each and what you might need to be tested for. So next slide. The metabolic endocrine causes, again, probably the most common thing that is tested immediately for because of the association of neuropathy with diabetes. So that's the condition that I have listed there first. Obviously, blood glucose measurements, glycine and hemoglobin, that's your A1C test for those of you who have had that, are usually the first line tests for this. They may, if there's some ambiguity in this, give you a glucose tolerance test. I've had a batch of those over the years, where basically you get a baseline test for your blood sugar level and your insulin level. They make you drink a very specific amount of sweet beverage, and then you get used for a pincushion for the next few hours. They take multiple blood draws to see how your blood sugar is going up and down in consort with your insulin levels. This is often, by the way, a good test for people who may be pre-diabetic, because it often reveals that your insulin levels overreact to a small glucose challenge like that. That may be successful in suppressing higher sugar levels for a while, but it's an indication that you may be on the road to diabetes. After that, some that are less well known. Hypothyroidism is a cause of neuropathy, and usually there are thyroid function tests such as TSH, thyroid stimulating hormone, that they'll check for this to make sure that that's not too high. Usually a high TSH indicates your thyroid is not producing sufficient thyroid hormone, but other function tests can actually include the levels of the hormones themselves. Some of you may have gotten tests for T3 and T4. These are, without getting too much into the chemistry, these are thyroid hormone level tests, and sometimes all three of them together can be a little more instructive than just a high TSH level. Hyperthyroid neuropathy often manifests itself first, as I said, as carpal or tarsal tunnel syndrome. Now, this is unusual because a lot of people think of neuropathy as affecting the feet first, and that is a common presentation. But sometimes people with this may have their wrists and hands affected first, simply because the carpal tunnel through which the median and other nerves of the wrist and hand run is pretty narrow and prone to compressive effects. People who have low thyroid hormone levels tend to produce a waste product known as mucin, which tends to cling to nerves and tends to make it harder for them to avoid compression. This can happen in the wrists, but it can also happen in the tarsal tunnel area, which is the analogous area around the ankles. So sometimes people are like, I'm getting these tingles in my ankles and they shoot into my toes. It might not be a bad idea to test for your thyroid function. Renal failure. Yes, unfortunately, people who have kidney function problems will often have neuropathy symptoms. It's just one of those things where toxins will build up and nerves are very sensitive to the buildup of toxins. Tests for this are the general test for kidney function, serum creatinine, blood urea nitrogen, which is a waste product that is produced. Basically, you want to make sure that those are in, reasonably good areas. And hopefully, if this is suspected, it's caught early, when the kidneys are still somewhat functional, and then you can treat both the kidney problems and the neuropathy together. And then this last thing down here, and I won't get heavily into this because I've often heard tell that explaining porphyria is like explaining alternate side of the street parking. It's very difficult to talk about. You can certainly look it up, or I can provide you with some materials, but it is an endocrine metabolic problem that involves the functioning of kidneys and glands in consort. They can test for urine porphyrins, but it is a possible, though rather rare, cause of neuropathy in this particular realm. Okay, I'll go on to the next batch. Here's the nutritional deficiency area. And some of you again know about, vitamin B12 deficiencies, which have a lot of effects, including neuropathy. They can result in certain types of anemias. They can result in problems with the central nervous system as well. It is definitely one of the things that should be tested for if people come up with a vague neurological symptoms that include neuropathy, if only because B12 deficiency is probably underdiagnosed. It's more common as people get older because the ability to break B12 out of foodstuffs is more and more compromised by a lack of intrinsic factor being produced in the stomach as people get older. And the other thing I tell people is that if you are a vegetarian or vegan, and you're not supplementing with B12, be very, very careful and make sure you get these levels checked constantly. Unfortunately, we are not cows and we do not synthesize B12 in our rumens. We unfortunately need animal sources to get this. It's been one of my arguments personally against being vegan. Obviously there are good and bad sources, but you can definitely get this, through dairy products if you're able to do that. Also obviously through fish, through poultry. It's very, very hard though to get adequate B12 on a full vegan diet unless you supplement. Fortunately, supplements are easily available and inexpensive. I said I'd talk about B6. You can get neuropathy both from a deficiency of B6 and an overabundance of B6. That's the B6 toxicity. It seems though, and again, I apologize because I have talked about this from time to time in various support groups, getting neuropathy from a B6 toxicity is difficult to diagnose because often the plasma B6 levels is not as definitive as you would think. People can get high B6 plasma levels even without taking a lot of B6 or supplementing with B6. And a lot of that has to do with some genetic abnormalities in the MTHFR gene, which is the methylation gene. Many of the B vitamins must have a chemical methyl group attached to them before they can be used by the body. But somewhere between about 8 to 15% of the human population, and possibly higher among Northern Europeans, seems to have a genetic difficulty in doing that. As a result, they can sometimes be taking very normal levels of this, but because the vitamins are not methylated, because they can't attach that methyl group, the levels build up in the body, and in the case of B6, perhaps to neuropathy causing levels. There are fortunately methylated forms of these vitamins that can be taken, but it is something that people who are aware of this need to watch out for. And for people who are having suspected vitamin neuropathies, it's definitely not a bad idea to get a genetic test for that particular mutation. Other things that you may or may not have heard about, it's possible to be deficient in vitamin B1 and actually get neuropathic symptoms from that. As it is with vitamin E and as it is with folate. Some of you may know that in prenatal vitamins, they throw folate in order to help prevent spinal bifida and other spinal deformities in the fetus. But it's possible for people to have folate deficiency when they're not in that state. Generally, if you're taking a multivitamin or you have a decent diet, this is not something that's that common. However, and this is something else I should mention before we get into more of the toxic causes, people who abuse alcohol or who abuse drugs tend not to have very good diets, and that's often where a folate deficiency might be seen. Obviously, if they're abusing that stuff, they have problems that may be causing neuropathy just from that, but it's also something that definitely should be looked at. Okay, let's go down a little further and talk about those toxic causes. I have the common ones at the bottom in this particular case, alcohol and chemotherapeutic agents. And as you heard me said before, a lot of the chemotherapeutic agents, a lot of the cancer drugs, particularly the ones that are based on heavy metals like cisplatin, are very neurotoxic. That's not particularly surprising because a lot of the heavy metals are neurotoxic. You notice I have lead in there and I have mercury in there. I mention this because these used to be fairly common causes of neuropathy, although neuropathy at those times was probably less understood. There were people who had professions, occupations that exposed them to lead or mercury quite often and who would develop neuropathy as a result of that. And it is turning out, and I know this because the gentlemen involved have been very, very active in the 9/11 advocacy realm. A lot of the people who were first responders down there have actually come up with higher levels of lead or mercury and other things, including, by the way, organic phosphates, which can cause neuropathy. And this has become something that while it has not been seen recently, it's been seen in that population. Arsenic, a lot of people know about arsenic as a poison. Well, one of the first things that attacks is nerves. There are people who live in places who actually have around them in their soil fairly high arsenic levels, which sometimes leaches into the groundwater. And if they don't have a good water filtration system, over time, this can build up and possibly lead to nerve problems. I want to mention the organic phosphates because this is something that has not only come up with people who work in certain industries, but people who work in like contracting, the individuals who might have been involved, for example, in using wood stains or certain types of paints in decorating buildings. We did have in one of my old groups in Long Island, we actually had somebody who was labeled as idiopathic, and it finally occurred to us to ask him what he used to do for a living, and that's what he used to do. And lo and behold, when they actually did some blood testing for this, it came up with fairly high levels. So it looked like that might have been a major part of his neuropathic symptoms. And the other thing that I just threw in here, although it's very rare, but it was something that I actually managed to diagnose for somebody one time, is ciguatera poisoning. This is a toxin caused by bacteria that tend to accumulate high up on the fin fish chain. It results in some other symptoms too, including gastrointestinal upset and vision disturbances, but it is well known for producing neuropathy. And for people who eat a lot of fin fish, you're talking things like not necessarily tuna, but sailfish, swordfish, grouper, things of that neighborhood. If they're in the Caribbean or Mexico, Baja California area, or places like that, and they've eaten a lot of finfish, they have to have that history, and they suddenly start getting some weird symptoms, this is something that should be tested for. And part of the reason I mentioned it is I had a very good physician friend who is Dr. Joseph McGinn. He was the head of heart surgery at Staten Island University Hospital. I had met him because he did 2 bypasses on my dad long, long ago, who had reported this to me. He tended to call me with neurological questions, which is interesting in itself, about this having afflicted a colleague of his on a Caribbean vacation. And lo and behold, the guy did have ciguatera poisoning. He had high levels of that. Very specialized testing was involved. It did recede in time, fortunately, and they were able to chelate some of it out. So it's one thing that I will remember for a very, very long time. Okay, that's the toxicity. Let's get into the autoimmunity, immune causes. I wanted to throw this in first here because we'll talk about some of the better known autoimmunities in a minute or 3, but these are some of the immune causes that are very specific to peripheral nerve, antibodies that for whatever reason, often, in terms of shape, will attack peripheral nerves. And what you probably need to understand in terms of shape, and this is apparently what happened to me, a lot of the time with autoimmunity, there is a phenomenon called molecular mimicry. This phenomenon basically posits that your body is attacked by a pathogen. Your body mounts an immune response, antibodies against it, may even fight off the pathogen. But if it turns out that pathogen has a shape molecularly like some component of the body molecularly, the now activated immune system may not shut off, and it may start actually attacking those parts of the body that are very much like the shape of that pathogen. A lot of the way antibodies work is by sort of being incompatible with the pathogen in the sense that they smother it, and their shape enables them to fit in like a key to the lock into that pathogen's molecular structure. It turns out that there are certain pathogens out there that seem to have some shapes to certain components of peripheral nerve. We listed them here, and again, I don't expect anybody to know specifically what these are. These are among the ones that were discovered at Weill Cornell and other places. But you can see here, you see the word ganglioside. It's basically a type of protein that's associated with nerve ganglia, which are collections of cell bodies. There are a batch of them here. And sometimes if there's no cause evident, one should be tested for these antibodies, which may be attacking components of peripheral nerves. Of the ones that are here, probably the best known are the ones that are not the ganglioside antibodies. The MAG antibody, MAG stands for myelin-associated glycoprotein. These are components of myelin sheaths, and there are definitely antibodies that attack them. These are often considered to be culprits in certain things like CIDP, as is the sulfatide antibody. Sulfatide is a component of the axon of the nerve, the actual nerve fiber. And it is, again, a molecule that apparently is shaped very much like the molecules of certain pathogens. And sometimes people will develop an autoimmune reaction to that. There are tests for these, by the way, but I mention them here because, again, unless you're at a well-known, tertiary facility, a teaching hospital, or you have a neuromuscular specialist in your corner, your average neurologist is unlikely to have heard of these. It's the type of thing that, comes out of major research centers. As opposed to, in this next slide, some of the immune causes that are a little bit better known, although perhaps not tremendously well known, and that come from the rheumatologic and vasculitic diseases. Often rheumatologists know more about this than neurologists do. These involve antibodies that interact with peripheral nerve, as well as attacking connective tissue and vascular structures. Probably the best known of these are lupus, systematic lupus, and Sjögren's syndrome. People know that lupus attacks a lot of tissues in the body, from the kidneys to the heart to the brain to the peripheral nerves. There are some specific blood tests that can be done for lupus, although there are other criteria for diagnosis, such as a face rash. But usually they're looking for some variation of the anti-nuclear antibody. That's the ANA that's listed next to lupus there, or the double-stranded DNA antibody. For Sjögren's syndrome, not only do they look for ANA, but they look for a whole batch of other antibodies, most specifically the SSA and SSB antibodies. Sometimes also the thyroid peroxidase antibody, which is often associated with autoimmune thyroid disease, because Sjögren's syndrome attacks moisture-producing and mucous membranes, and part of the neuropathic attack in Sjögren's comes from the drying out and damaging of nerve cells. Other things that are here that are related, often considered to be in the same family, things like polyarteritis, which is another disease, particularly of vascular tissue. You can see here that sometimes you can also get this from hepatitis B and C serology. We're going to talk about those when we talk about infectious causes of neuropathy. Rheumatoid arthritis, obviously they look for rheumatoid factor there, and something called the cyclic citrullinated peptide antibody, say that 3 times fast. Granulomatosis, otherwise known as Wegener's syndrome, where they look for the anti-neutrophil cytoplasmic antibody, which is an antibody against a particular type of white blood cell, labeled ANCA for short. And then I also have on here something that's a little bit different because it's not really a vasculitic disease in the same sense, but celiac. Celiac neuropathy is a thing. They look for either the gliadin or the antitransglutaminase antibodies. Approximately, from what I understand, 50% of people with frank celiac will have some neuropathic symptoms. And it's not only peripheral nerves that get affected, it can also be the central nervous system. There is a condition known as cerebellar ataxia, which attacks the cerebellum, which coordinates motor movements in the brain, that is also not uncommon in celiac. So since celiac appears to be more common than we have thought, again, particularly among people of Northern European and Mediterranean ancestries, it's definitely something to look at, particularly if you have some other symptoms there, gastrointestinal upset, or in children, failure to thrive. But it's certainly true that sometimes the first indication of celiac gluten problems has been a neuropathy. Oops, I skipped over something that I didn't want to. Okay, so here, that's the immune causes. Let's talk about the paraneoplastic cancer-related stuff. Again, the one that some people have heard about is monoclonal gammopathies. These occur when the bone marrow produces basically monoclonal antibodies that interact with peripheral nerve. These can be in many different classes. There are immunoglobulin A, immunoglobulin M, immunoglobulin E, different areas with this. They tend to produce pretty much similar symptoms, which is a sensory first and then possibly a motor neuropathy, attacking both axons and myelin sheathing. They are associated with certain blood cancers, such as myeloma and chronic lymphocytic leukemia, which we have here. They're also associated with macroglobulinemia, which is sometimes also referred to as Waldenstrom's, again, a type of blood cancer. Generally, the first line test for this is something called an immunofixation electrophoresis, an IFE, to look for these unusual proteins in the body. They are things that do show up much more with age. Approximately, I think it is said about 1% of people over 50 have these, about 10% of people over 80. They don't always necessarily mean that there's a blood cancer there, though that should be checked for. Approximately 2/3 of people who show up with these wind up with a condition known as monoclonal gammopathy of uncertain significance, otherwise known as MGUS, MGUS. However, such people are very likely to have neuropathy. There seems to be a cross reaction with these antibodies and components of peripheral nerve. I also want to talk about lung cancer, although this can be extended to probably ovarian and testicular cancer as well. Particularly small cell lung cancers tend to produce, as part of their etiology, different antibodies that can be tested for that seem to, again, cross-react with nerve and result in neuropathy. The most common one for lung cancer is the HU antibody, the WHO antibody. The Re and the Yo antibodies can show up and often show up in gynecologic or testicular cancers as well. So yeah, the unfortunate thing is you can have cancer, you can have neuropathy from the cancer. The treatments that you might get might also cause neuropathy. I guess the only thing is to have an honest oncologist in situations like that. And I will mention at the bottom, although it's related to the other things I was talking for, primary amyloidosis. This is, again, a result of those monoclonal antibodies, and it's when they get thicker, it's when they get more numerous, and they start to form actual tendrils that interfere with organ function. Generally, if you have primary amyloidosis, your biggest problem at that point is probably not neuropathy, because they tend to interfere with heart and kidney and lung function as well. But again, it's something that happens to people that have a number of different blood cancer conditions. So now that I've depressed everybody with that, we'll get to stuff that maybe is a little less depressing, because more of these have treatments. Infectious and inflammatory causes. Yep, a lot of things, a lot of bacteria and a lot of viruses that will infect you can cause neuropathy, either through direct action and invasion of the nerves or through the antibody molecular mimicry that I was talking about. And of course, the most common one that is known about is AIDS. The HIV virus can actually infect nerve. It certainly causes problems, obviously, in the disruption of the immune system. But this is something that is common among people who have HIV infections. Fortunately, now we have drug treatments for this, and it is the type of thing that if people have experienced neuropathy, if they get on their PrEP drugs and they actually have undetectable levels of virus, the neuropathy from this often will fade or at least get better with time. And that's a piece of good news. Lyme disease. What doesn't Lyme cause? Well, yes, Lyme invades nerves. There's definitely a lot of controversy about Lyme disease, hopefully less now than when it was like first really described back in the 70s. But obviously, the Borrelia burgdorferi, I hope I'm pronouncing that right, Bergdorf. I always think of Gary Bergdorf for that, Bagdorferi. Bacterium can invade nerves. If this is considered to be a possible cause, obviously they should try and get the Western blot or the ELISA tests to determine if those are there, particularly the antibodies to them. Other things that are in this category, herpes zoster. For those of you who know about this, really all of the individual herpes types of viruses, I'll talk a little bit more about them later if people want to hear about them, can cause neuropathy. Basically, the one that causes chickenpox and later on such thing as shingles is considered to be human herpes virus 1. There's also human herpes virus 4, which is Epstein-Barr virus, which can also be involved here. There's human herpes virus 6, which causes 6 disease. There's a lot of fun stuff here. So anyway, there's also cytomegalovirus, CMV. This again is something that a lot of people get infected with. They get symptoms that aren't that much different from bad cold, but in certain cases, this can also cause neuropathy. Certainly, hepatitis can cause neuropathy through direct invasion of nerve, not just of the liver. Hepatitis B and C. As a result, we tell people, yes, if there's like no indication of this and you have a history of it, please get tested for it. Fortunately for hepatitis C, there is now a treatment. I don't know though, because it's so new, whether the people who have suffered neuropathy from hepatitis C, whether the neuropathy has gotten better with treatment or the elimination of the virus. And one other thing to talk about, sarcoidosis, okay? This is a granular disease caused by a bacterium. It often infects the lungs, but it can actually also infect peripheral nerve and the central nervous system. One of the things that we tell people with this is, since it's very hard to diagnose, even with the test for the angiotensin converting enzyme, which is an indication of its activity, is to really go see if they can, someone who specializes in granular and other lung conditions, people who might be pulmonologists with a pneumonia background. This is something that, you know, is very, very difficult to diagnose. Sometimes the only evidence for it is a particular type of X-ray or CT scan evidence in the lungs. Okay, now, next thing, compressive causes. These are fairly easy to explain because obviously, if you are compressing a nerve, whether it's with a prolapsed disc, a herniated disc, arthritic spurring in the spine, you might get neuropathic symptoms. These generally don't involve blood tests so much as they involve imaging tests and a clinical history. But obviously, spinal stenosis of many different kinds can cause neuropathic symptoms. The most common place is the lumbar sacral spine, lower back, where you might get symptoms down the legs into the feet that may be hard to distinguish from other types of neuropathy. Obviously, for these, you need imaging. MRI is probably better than CT scan. Sometimes directed nerve conduction studies can provide a hint to this, because if it's only from a certain point down, that sort of points to a more localized neuropathy rather than a systemic one. But of course, trauma can produce very similar types of symptoms. Obviously, if there's suspected trauma, there is a history here. There's an accident, there's a fall, something has happened. These are the type of things where the prognosis is very variable in that injured nerves can heal, but often the healing is incomplete. It seems as if in some cases there may be some luck with nerve grafting or other types of surgical workarounds, but it's certainly a cause of neuropathy. We mentioned carpal tunnel before, and of course I mentioned tarsal tunnel before, so we'll go over that real fast. But yes, carpal tunnel is probably the second most common neuropathy after diabetic neuropathy. And of course, a lot of people don't even recognize it as such. It has become more common over the years because nowadays we're all keyboarding all the time. I'm wondering if the generation that's coming up more with phones and touch screens as opposed to keyboards will experience less or more carpal tunnel syndromes, but it's very, very easy to develop over time simply because that area is very prone to compressive forces. It's a very narrow channel. A couple of things to mention that are rather unusual. Neuralgia paresthetica. Again, say that 3 times fast. This is a condition of the lateral femoral cutaneous nerve that runs from the outside of the hip down the outside of the thigh and ends near the top of the kneecap. There are people who have suffered terribly with this over the years, and it generally comes from a compression either within the pelvic area itself or slightly further up. It's the kind of thing where Some treatments have been tried that include nerve ablation. The problem with nerve ablation is that you may kill that nerve or burn off a lot of that nerve, but nerves over time do have a tendency to regrow, and it's the type of thing that in a couple of years may come back. Some people do decompression surgery to try and get fat pockets out of the hip or side area, if that's feasible, and if the person has such pockets there. But it's one of those unusual things that can be quite debilitating. And something that I suffer from to a certain extent, pudendal neuropathy. Yes, this is what you think it is. This is neuropathy of the pelvis and the genitalia. It tends to be a little bit more common in women than in men just because of anatomical situations, but it is not unknown in men. I have a version of this sort of as like the legacy of my neuropathy that bothers me from time to time. It means I have to watch very carefully how I sit. I am on a very soft pillow right now because this is the type of thing that can produce symptoms going through your entire pelvic and genital area. And I will tell you, these are not the nice kind of symptoms you might want. So it's the kind of thing where if you're experiencing that, some imaging should probably be done there. And this has often been treated, as some spinal things have been treated, with injections into the pudendal area, often in the Alcock's canal, which is in the back of the butt, to see if they can reduce the inflammation, swelling, and the pressure on the nerve. Again, not a fun thing to have. Okay. Now, one more thing, and I'll just talk about this like pretty quickly because, as I said, next month we're going to have Linda Pettio talking more about hereditary causes. But there are a lot of them out there. That's the many, many others. Charcot-Marie tooth is the most common hereditary neuropathy known. It was also probably the first one discovered. It's named after the three physicians who were involved in the discovery. The tooth does not refer to anything you chew with. It's Dr. Charcot, Dr. Marie, and Dr. Tooth. Yes, a Dr. Tooth. Should have been a dentist. But this is something that can be determined through genetic testing. There are a number of different variations. It does tend to produce both sensory and motor symptoms. Now, the sensory ones tend to come first, the motor symptoms later. It is often associated with that rather common neuropathy problem of drop foot. So you do have to be careful. And if you're experiencing that symptom and you don't have another cause that you know about, it might be worth getting the genetic testing here. As I said, there are a number of different variants involved. And one that we do want to mention, and it actually is based upon the experience of one of the people that we have in our support groups, who may be online with us now, I don't know, transreferrin amyloidosis, which is not like the other amyloidosis that I spoke about before that results from monoclonal antibodies. This is a genetic condition, very rare, but in its effects, it invades various organs, including nerves. It's the type of thing that has to be done through specialized genetic testing because the immunofixation electrophoresis will not show this because it comes from a different cause, which is a genetic mutation. We do have one person in one of our support groups, whose name I won't mention, but people know who he is if you've been in there, who got tested for this. Fortunately, there are some treatments for it now, but he was very, very grateful to find out about this, even though it is so rare that it's estimated only about 3,000 people in the US have this affliction. There are many, many others. I'm sure Linda's going to talk about them. I mentioned hereditary neuropathy with liability to pressure palsies before. There are numerous ones that one can find out about through that Washington University neuromuscular database, which goes on forever. So hoping that like you've all recovered from all this, I want to talk about how you get this considered. And it's basically about knowing these type of things are possible and not feeling that you can suggest them to your doctors. Now, admittedly, some doctors are easier to suggest things to than others. And if you're getting your neuropathy examinations in a tertiary center or a teaching hospital, it may be easier to talk about this with the physicians present because they may have heard about a lot of all this stuff. But I realize that's not possible for everyone. So what I often tell people to do is to pull out or even print off, if your first visit is going to be with somebody who's not a neuromuscular specialist, whatever specialty they have, these two particular papers that are part of the presentation that I did for neuropathy websites everyone should know about. The first one is an algorithm for the evaluation of peripheral neuropathy. A very important paper. It is the leading paper on neuropathy in the American Association of Family Physicians database. It was created by Ann Poncelet of the University of California, San Francisco. And even though it's fairly old, it's 25 years old now, 1998 she published it, it's still probably the best general evaluation for figuring out causes of neuropathy that I know of. Certainly there have been additions, particularly hereditary ones over time, but it's short, it's easy to read. It's got a flow chart, which is very useful. So you can see what happens if certain tests don't pan out or do and what to investigate next. And it's something I think that everybody with neuropathic symptoms should at least be familiar with and should try and get their doctors to be familiar with it too. The other one has a very, very similar etiology and a very, very similar utility. It's laboratory diagnosis of peripheral neuropathy at the Quest Diagnostic site. This is the paper I mentioned before that Norman Latov partnered with Quest Diagnostics in how to determine causes of neuropathy through serological testing. And they don't mention anything about EMGs or imaging or anything there, but this is all about, hey, if you have certain types of symptoms and you suspect certain things, here are the tests that might help you, if not to confirm, at least to rule out various different causes, particularly when you get into some of the unusual things like the monoclonal gammopathies or the possible toxic causes or nutritional causes. And so everybody should be familiar with this as well. One can actually access these, by the way, on the Western Neuropathy Association website. My presentation is there, and I do believe we have a direct link to them now, basically called, useful neuropathy websites to know and love, as well as there's a batch of other good neuropathy websites there, including that Washington University website that I mentioned about, the Washington University at St. Louis Neuromuscular Database. Okay, I've been talking for far too long, so we're going to see if I can take a break, have Daryl come back in here, see what's in the Q&A. I don't know if there's anything in the chat. Sometimes people throw stuff in there, but let's see. Come on back, Daryl.
All right, I'm back. So in here, let's see, in terms of the Q&A, let's say a first one I've got here is FGFR3 antibody is, I guess it is FGFR3 related to PN.
Yeah, there are more and more antibodies to particular components of peripheral nerve that are being discovered all the time. I'm not familiar with every single one out there. I wouldn't be a bit surprised. I do know that there are a whole batch of other ones in the database now that I even have to go take a look over and see. But yes, there are so many immune-mediated neuropathies out there, and probably will keep on adding to that database as time goes on. And there's a question about statins in there.
Yes, there is. So one of the questions is, what medications are known to cause PN, and then statins is a question mark.
Statins have definitely been implicated, although more for myopathies, breakdown of muscle tissue. Obviously, breakdown of muscle and breakdown of nerves can be related, but a physician who has a patient and the patient has a history of neuropathy should be very careful about prescribing statins and should probably prescribe as low a dose as would be possible to get the effect of cholesterol lowering, and possibly should also be looking at other particular ways of lowering cholesterol as well, such as like niacin, and even dietary changes. Eating a lot of oats might even help with that. It's very, very tricky. And depending upon what papers you look at, there are an awful lot of papers that will say, yes, there is an association in some people with mitochondrial damage from statins that result in neuropathies and not in others, or it's not proven. But I think it is definitely a need to be cautious in this. Now, since we're mentioning it, because I didn't even get into the iatrogenic causes of neuropathy, which basically translates into neuropathies caused by other medical treatments, unless you're talking chemotherapy. There are some drugs out there beyond the chemotherapeutic agents that are known to be somewhat neurotoxic. The most common one are the ciprofloxacin class of antibiotics. Hopefully you don't have an infection that gets to the point where you need those incredibly strong antibiotics. But that is another group of drugs out there that is known to have neuropathic problems. And if one needs to take them for particularly virulent infections that are antibiotic resistant, you definitely should discuss this with the physicians and probably the pharmacists to try and minimize possible damage and minimize the dosages that would be necessary.
Hey, you want another one? So
Katie has the thing about IgM neuropathy. Yeah, we were talking about this with monoclonal gammopathies, Katie. That's IgM is one of the classes. You have IgM, IgA, IgG. These are all part of the monoclonal gammopathies, the monoclonal antibodies that are erroneously produced by bone marrow, and then can have effects on nerves as well as other effects within the body. And now, can you group these different causes into groupings of those that can be treated and those which have no known treatment? Not as easy as you would think, because within each of those 8 groupings that I have there are some that are treatable and possibly others that are not, and this changes over time. I think in general right now, the least treatable causes are those that are hereditary in nature, simply because with the inability yet to go in and alter your genes after you're born, it's very, very hard to get those genetic instructions to be overridden and to produce more normal proteins. So that's probably, out of all of them, the biggest problem. All of the other ones that are there have some things that are treatable and some things that aren't, although sometimes the treatment is more palliative, it's more symptom reducing. Obviously, for things like the inflammatory infectious neuropathies, if you can get rid of the infection, you can get nerve recovery over time, but you got to get rid of the infection. Same thing with the toxic causes. There are a lot of people who have noticed at least some recovery after their chemotherapy was over. Not as many as we would like. But there are other toxins, if you can get, lead and arsenic and things out of the body, nerves will heal given otherwise good conditions. It's slow, it's patchy, it's incomplete, but it can happen. Among other things that are treatable, certainly compressive forces are. If you can actually remove the compression, whether it's through physical therapy, whether it's through surgery, you can give the nerves a chance to heal. Even a number of the autoimmune conditions can be treated with things like intravenous immunoglobulin, IVIG, with plasmapheresis, which involves replacing and filtering the blood to get rid of those rogue antibodies. And some people even get some work with some of the vasculitic autoimmunities through the application of steroids, although nobody wants to be on steroids for a very long time because they have their own side effects. But most of these things, there is at least some ability to treat, or possibly what I should say is some ability to improve. The biggest problem is if you have an idiopathic designation, the problem there is you don't know what to attack and you don't know what to treat. That's the biggest problem of all with that. And I am fairly certain that the numbers given, like for idiopathic neuropathies, that there's about 1/3 or so of all people with neuropathies are idiopathic. I don't think it's that much. I think that's the result of insufficient testing and investigation. Right now, if we really go down the rabbit hole of testing, maybe it'd be closer to 1/5, possibly less. I had told people that you tend to be a lot more idiopathic in a local office than you do at Weill or Hopkins or the Cleveland Clinic, where they can test for all this type of stuff. The difficulty is that there's probably causes, autoimmune, possibly some metabolic, certainly hereditary, that we just haven't discovered yet. If you had come to me 20 years ago and talked about hereditary neuropathies and you had been diagnosed idiopathic, I would say, maybe you have a familial condition passed on we just haven't seen yet. So many of those have only been discovered in the last couple of decades. I don't know how far that goes in terms of answering the question, and it brings a lot of other things in. It probably goes to, I always have a feeling when I see anonymous attendee that it's Catherine. What percent of neuropathies sources are never identified? Yeah, they usually give that 1/3 figure, but it's probably lower at tertiary centers. Have you ever heard of a vaccine that causes small fiber neuropathy? Yes, not common. It happens. It's part of the molecular mimicry situation. It's introducing things into the body that perhaps the immune response will also cross-interact with nerves. I'm still a fan of vaccines, though, because often what you're trying to prevent with the vaccine is a lot worse than having the neuropathy. And the number of cases where this has happened is small. There are definitely cases of Guillain-Barré and CIDP that have been triggered by a vaccination, but a very, very small number. The odds are generally in your favor if you get the vaccine. Also, some people, I think there were 8 cases reported in the United States with the COVID vaccine that were documented. And considering how many millions of doses were given, I'd still go out and get the COVID booster, even with my history. Okay, what else do we have here? Lynn says, if you know the cause of extended, what good does it do since there are few cures? Well, part of it, Lynn, you're right. In certain cases, it may not do much good, except for the fact that you may find a treatable or palliative cause that you can fight. And it does help with diagnostic categories for things like getting disability. There are definitely people out there who were experiencing severe pain or motor symptoms from neuropathy that had trouble getting disability while idiopathic. But if they went back and got testing, and now it says, oh, this person has an autoimmune reaction to the GM1 antibodies, that's a lot harder for the Social Security judges to dismiss. So that may be one reason to do it. Oh, and Susan's talking about piriformis injury. Speaking of compressive neuropathies. Yeah, for those of you who don't know about piriformis, the piriformis is a muscle in the back of the thigh. The sciatic nerve passes through it. However, in possibly, again, something like 15 to 20% of people, there are positional variants where the sciatic nerve becomes very prone to compression by a tensed or built up piriformis nerve, a piriformis muscle. There are people who are bike riders who report this. They build their thighs and didn't have problems before, and then suddenly they get sciatic symptoms. But certainly, yes, one should look at pudendal neuropathy as well, because certainly you can get muscle or tendon compression in the pelvis. There's an awful lot of things that pass through the pelvis that can be compressed. And, it's often hard to pull these out. Oh, see, now I'm wrong because Catherine has pointed out that the website is being edited and notice that the link for Glenn's essential websites is not active. Thank you, Catherine. That is important to know. So please check back. Yes, get those essential websites up there. You want to take them to your next appointment. Let's see. What about Losantin, ARB? Not something I know about. I'll have to research that. Let's see. What else? What else do we have here? Are there toxic ingredients in suntan lotion? Good question. There's certainly been speculation about this and it getting past the skin barrier. I do wonder if that is actually the case. I tend to go with zinc oxide, which is just very, very thick and is used more as a blocker than as something that gets absorbed into the skin. I do believe, though, I mean, this is certainly important. I think we're going to find a lot of neuropathies caused by chemical exposures that we've been guinea pigs for the last century or so that we weren't really aware of. Certainly when the Food and Drug Administration and other organizations out there tend to allow substances to be used, the testing that they do is not long-term, it's not decades. And I imagine that there are many of these chemicals out there, if we're exposed to them over decades, and some people might have neuropathic effects. And what else is in here? I'm trying to see what I skipped on. B complex. What else do we have? Is there neuropathy from seronegative autoimmune disease? I would think so. Rheumatologist does not believe in Sjögren's syndrome. Also have endometriosis, celiac, and low thyroid, but neuromuscular doctor is not concerned. Hey, you could get neuropathy just from the celiac and the thyroid problem. So, I mean, certainly you might, you can be comorbid. None of us is, my line is none of us is excused from being comorbid. You can definitely have neuropathy from more than one cause. And sometimes, by the way, you get what is known as double crush syndrome. That is where a systemic neuropathy that damages nerves is then made worse by compression on those nerves. And the symptoms are all out of the sum of their parts range. The most common one is when diabetics get spinal compression, and they tend to get really bad symptoms, more than you would expect from either the diabetes or the spinal compression, because the nerves are already damaged and then they get pressed on and they scream. B complex vitamin supplement has B6 as well as all the other B vitamins at high levels. Is it possible? Yeah, we were talking about this, that the B component can actually lead to neuropathy with this supplement. I guess it depends on how much you're taking and whether you can methylate them, John. I have yet to see in the clinical literature, and I look at a lot of clinical literature in 3 languages, where people without the MTHFR mutation got neuropathy from overages of B6 unless they're taking some ridiculous B6 amount, like 1,000 milligrams a day. Considering that the basic range, in terms of the blood is somewhere like 5 to 21 is considered normal. And I'm not sure why people would be taking that much B6, but it's possible, as I said, to get the B6 toxic neuropathy if you're taking normal amounts, but not methylating it and metabolizing it properly. In which case, you may just have to avoid B6 for a while, or if you take it, take a methylated form. That's the, if I'm not mistaken, that's the pyridoxine 5 pyridoxal form. That is the methylated form, which you can purchase over the counter very easily. Okay, Peggy is saying, I have recurrent herpes zoster simplex, which I'm sure is a real pain. Oral progressed Ramsey, yeah, okay. Wait, let me get back to that one. People keep posting. Could this actually be causing my SFN? Yeah, you should also get examined for other things. Again, We're not, comorbid, but certainly anybody who has infection with any one of the herpes viruses, the human herpes viruses, these have all been implicated as infectious causes of neuropathy. What do we have back here? Okay, Cheryl is saying, I had most of my thyroid removed in my 20s. Oops. Every time somebody posts, it gets moved. And pathology showed Hashimoto's. Okay. So autoimmune thyroid disease. I've been a thyroid mate. Can my small fiber neuropathy still be contributed to my thyroid condition? It's possible. And the fact that your T3 is very outside of normal does make it suspicious. I mean, yes, that would be expected with the removal of most of your thyroid. And, it's possible. I would certainly say, get the other testing, at least for most of the other causes as well. And again, it's not something that would preclude you from having other causes of neuropathy. But yes, I think thyroid neuropathy for underactive thyroids or autoimmune thyroid conditions is probably underdiagnosed. It's not something your average endocrinologist thinks about. And yet you would think they should, because they're probably familiar with diabetic neuropathy. So, and now Richard is like, any comments about multifocal motor neuropathy? Well, beyond the fact that it's there and it's autoimmune, and often some of those antibodies we talked about are implicated in it. It's certainly something for which treatments can be tried. Certainly it's related to CIDP, and it's the type of thing where if you can get IVIG, you can get plasmapheresis, you may be able to at least stymie it or maybe get some improvement with it. Is neurogenic bowel neuropathy? Technically, Susan, yes, but it's probably a neuropathy that's autonomic in nature, and it's probably going to be associated with a lot of other things as well. What I can tell you is that people with small fiber neuropathy of the unmyelinated nerves, very often have autonomic symptoms as well. Their stomach doesn't empty properly. They're constipated. They have problems with blood pressure or under or over sweating. This is common in small fiber syndromes. It's often not that noticeable for many people with subclinical, but certainly people who are diabetic or have other small fiber syndromes definitely should be examined for this. There are a lot of diabetics out there with autonomic symptoms, particularly gastrointestinal ones. Compression hose hurt or make neuropathy better? Depends upon how much they're helping your circulation. I think that's a very individual thing. Some people swear by them. They say it helps their circulation, which brings more oxygen and nutrition to the nerves, enables them to carry away waste products. But some people just hurt from the compression. I tend to use more of the socks that are designed for diabetics, which are very soft. They're also white. I do not have diabetes. I have pre-diabetes. I'm trying to keep from getting diabetes. But generally, you want those socks where it's easy to examine your feet, or if for some reason you get, if you do have diabetic neuropathy and you have numbness, if you do get some sort of wound on your foot, you want to be able to notice it. There are a lot of people out there who get wounds on their feet and don't notice them if they don't examine their feet, simply because their feet are numb. And you want something where like any sort of cut or blood would show up. Do nerves cut during surgery regenerate? In general, the answer is yes, but not always in the same pathways and not always completely. Nerves do regenerate. I'm living proof of that. I've had many skin biopsies over the course of my neuropathy for 20 years. And it is obvious, like, when they do them every 2 to 3 years, that I have greater intraepidermal nerve fiber density. But it's probable that I'll never get back to my original density. The recovery will be incomplete. And I do tell people that yes, part of the problem and part of the reason you know that nerves regenerate is that people with compressive neuropathies that often have nerve ablations or other surgery to stop the nerve symptoms by cutting them, often year, 2 years, 3 years out, will wind up sometimes saying, hey, I got my symptoms back again because the nerves have regenerated. So let's see, did I cover all of this? I think there's some stuff in the chat too. Any questions in the chat? Oh, okay, this is links to pnhelp.org.resources in the chat. Yes, you definitely should go. I know we're going to post this chat on the YouTube site. Probably it'll be there in a week or so. And, it's good to take a look at our YouTube site anyway, because we have a lot of presentation and material on that. All the webinars go there. You can see the presentations we've done over the years at our medical conferences. A lot of good stuff on there, and it doesn't get near enough views. So
there's one minor change to one of the questions. Barbara, well, it actually isn't minor, but Barbara Crawfield had said that she mistyped her.
right.
So losartan for hypertension.
Yeah, losartan. Yeah, I mean, I know what she's talking about. But yeah, I mean, certainly some people again have implicated it, but probably I don't think there's good unequivocal clinical evidence yet. That doesn't mean people may not be suffering from it though. Now oh yeah, Peggy, I am not getting IVIG. I never got it because unfortunately there was never direct evidence of autoimmune involvement with me, although that's what's suspected, except for an unusual result on a specialized test at Cornell called the ganglioside agglutinin test, which is something they only do there. But given the etiology of my neuropathy, it's probable that autoimmune molecular mimicry mechanisms were involved. But eventually, after destroying most of my small fiber nerves, it burnt itself out. And then for about 17, 18 years, I've been trying to recover. Are some causes more related to neuropathic itch, says Linda? That's a very good question, because I don't know if there's any really good research out there about why some people get itch, some people get pain, some people get tingling, some people get like electrical shock, some people get numbness. It may have to do with the particular nerve fibers that are being preferentially attacked, because certain small fibers are related to itch, certain are related to pain, certain to temperature sensation, certain are autonomic. So it may just be what's eating you at that moment, or what's eating more of you at that moment. But I mean, people with all these different causes get all different sorts of things. There are plenty of diabetics out there whose main symptom is neural pain. There are probably almost an equal number whose main symptom is numbness, when those small fibers have basically given up the ghost. Some neurologists will actually tell you that if you're suffering terrible pain, that's a minor neuropathy, because it means the nerves, while damaged, are still functional. But it's a major neuropathy if you're numb, because the nerves are dead. So that's what passes for neuropathic humor in some of those offices. Okay, what else do you, anything else down here?
What if you have all those symptoms?
What if you have all of those symptoms? And yes, people do tell me, particularly in groups, that like, how is it possible for me to have pain in my toe and a millimeter to the right of my toe, it's numb? Well, those nerves are microscopic. In one part they may be damaged, in another part they may be dead, and they may be very close together. If you think about small fiber neuropathy, in order to actually examine the nerves, you need an electron microscope. That's how tiny the nerves are. You can have thousands of fibers in a single cubic millimeter or cubic centimeter of skin. And yeah, I'm sure, many people do have all these symptoms at once, unfortunately.
Yeah.
So what else can we tell you?
I think that covers everybody's questions.
I know, I keep looking like, because every time I go in the Q&A and somebody puts another question in, the thing moves and I have to go look
Yeah.
again.
So here's
Is there,
another.
here's another question. Is there a specific significance for drop foot on one foot, but not the other? Probably not, just in the sense that you may just have more damage in that foot now, but I suspect if you have a systemic neuropathy and you have drop foot in one foot, you may get it in the other. Now, if you have a more localized neuropathy, you basically have compression on one side, you may get drop foot only on one side. You know, a lot of it may depend upon what your cause is.
Well, I
Okay.
mean, we've gone pretty well over and well in well-meaning.
Oh, who uses an electron microscope? Well, generally not the dermatologist. The
No.
dermatologist will generally send them off to specialized pathology departments. There's only, I think, about 24 facilities in the US that actually do the electron microscope examination of small fiber nerves. The obvious ones like Hopkins and Cleveland Clinic and Weill Cornell and Massachusetts General, the Jack Miller Center in Chicago. These are often centers of excellence for neuropathy, where a lot of the research is done.
Okay.
I keep looking to it. Is there going to be another question?
Oh, I know. I think it could continue quite a while. So I think we should go ahead and close. Again, we want to mention that this will be up on our YouTube channel in about a week. Please feel free to take a look at it and review all the things that Glenn's gone over. He's done an amazing job. Thank you very much, Glenn.
Okay, thank you very, very much for all coming here today. Remember that our support groups are running. The next one is Saturday for those of you who need to get in there. If you're on our list, I'm certain you've gotten an email about it by now. And also remember, we try and do these, as I said, about once a month. June 22nd, Linda Petio is going to come and talk in even more exhaustive detail about hereditary neuropathies.
Okay. Look forward to it.
Okay. Thanks you all for coming. Thanks, Daryl, for having me. Thanks to the office for helping us out with all this.
Mm-hmm.
Of course.
All right, we're going to close the webinar for now. And thanks again, Glenn.
Okay.
Thank you.
Enjoy.
Bye.
Bye-bye.